Hi, I'm Dr. Keith C. Ferdinand, cardiologist at the Tulane School of Medicine, professor of medicine at the Tulane Heart and Vascular Institute. Today I would like to address disparities in racial and ethnic minorities. First, I will talk about some of the current data on disparities specifically related to hypertension and cardiovascular disease. I then will address the socioeconomic factors, also known as the social determinants of health, and how these impact disparities. And finally give some practical solutions how we as providers can address these disparities. Health and overall wellness has improved for all Americans over the last 2 decades. As the health has improved, however, there's a real gap. And since the 1960s, there's a gap in mortality, whites versus blacks, driven mainly by cardiovascular disease. African Americans have more hypertension, diabetes, obesity, especially in black females, chronic kidney disease, end-stage renal disease, heart failure, premature heart attacks, and an increased death from strokes. These drive these disparities. In July of 1964, Martin Luther King looked over the shoulder of Lyndon Johnson as they addressed socioeconomic disparities in access to public accommodations. The civil rights legislation was landmark. But as we've gone forward, specifically as it relates to health, probably more than biology or genetics, these social factors now have to be addressed as it relates to the disparities in cardiovascular health. If you look at some of the latest data as it relates to cardiovascular health, you will see that African Americans have more hypertension, earlier onset, more premature hypertension, death from heart failure, premature myocardial infarction, and death from strokes. These are not driven as much by biology, but as by the fact that the social determinants of health, where people live, where they play, where they work, all affects these outcomes. Furthermore, going forward, we know that race and even ethnicity are social terms without really true biologic factors. Nevertheless, if we don't address these social determinants, universal health care, access to a primary care provider, appropriate referral to specialists, we are doomed to see these disparities persist. The Institute of Medicine in 1960 suggested that there were real disparities in cardiovascular care. Now, in 2018 and going forward, we need to do more to address these disparities. In fact, the social determinants of health probably have more of an impact than any biology or genetics as it relates to race and ethnicity and outcomes in cardiovascular disease. Now, if you look across the United States, the Southeastern Conference is good for football, but bad for cardiovascular disease. In those areas starting in East Texas, Louisiana, Mississippi, Alabama, Georgia, into the panhandle of Florida, North and South Carolina, parts of Tennessee and Kentucky, and even into Appalachia, there are high rates of cardiovascular disease, including heart attacks and strokes. In these areas, you have a large number of persons who are uninsured. This uninsured status leads to poorer outcomes. People who cannot afford medications cannot have access to care. Now, one realistic component of this is a large proportion of African Americans who live in these areas. The legacy of slavery was overcome by the civil rights legislation, but perhaps some of the downside of what we have seen for centuries in the United States are disparities in health care. If you look at the map, you will also see that those persons who are uninsured have an increase in non-adherence. That is, in those areas where people don't have means, they're less able to afford care, not only including medications, but simple access to primary care providers and specialists. Those persons will get care, but their primary source of care will be the emergency department. When do you go to the doctor? When you're sick. What doctor? The ER. When you have chest pain, shortness of breath, leg swelling. A landmark study done decades ago was called the 8 Americas. Chris Murray from the University of Washington cut Americas into certain segments, looking at real life expectancy and longevity. Inner city urban blacks had a shorter life expectancy than other parts of America by as much as 10 years or more. This was found both for men and for women.